Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
There you go. Welcome aboard, everybody, and aloha. Thank you for joining us. You know, we've been doing the show for well over a year now. Dr. Randall Juliff, medical director of the Vein Clinics of Hawaii, 4 locations on neighbor islands, on the Big Island, on Maui, on Kauai, and here on Oahu. And interestingly enough, we've been talking about this. I assume that everybody listens to the show. You guys are all geniuses and vein experts like I am. I'm not either, but I've been sitting around and learning a lot of stuff for a long time, all thanks to Dr. Juliff. And one of the things that you're going to find out is in this profession, in the specialty that Dr. Juliff is, it is pretty organized. And it's to a point where we have to go backwards sometimes to go forwards. And forgive me for assuming that you all know everything. So today is the basic building blocks of what is venous insufficiency class 101. Is that a that's a great way to say, hey, look, this isn't, oh yeah, you have a vein issue. There is a real path that you can go through with us to explain, number one, what venous disease is, and number two, how soon can I find out where on the chart I am? At what point has this disease got me, or is it going to get me?
Right. I guess you could call this, Vein Disease 101, because I'd like to do kind of a little summary of, what we think about when we're looking at a vein patient and considering where on the continuum of the process they're in, because vein disease, unfortunately, is not something that we cure people of. Mm-hmm. We manage their venous disease, and that's because of the fact that most of the time venous insufficiency is a genetically predetermined kind of problem, and we're not changing we're not making a difference in their genetic makeup. We're just treating their problem.
One thing I can tell you, and I've learned this, and I'm sure that everybody listening is heard or seen, particularly when it comes time to things like cancer. When somebody is stage 4, they know that is at the bad end of stage 4. Right. And from what I understand, the system of grading or identifying things throughout your specialty is that pretty much if I'm a patient of Dr. Smith's in Nebraska, and now I'm a patient of Dr. Juliff's in Honolulu, that the information that he's already gleaned on me to give to you is going to identify where I am on the chart. Yeah.
We call this for vein disease, we call it a classification system, very much like the grading system of cancers. And I think that probably the way that this was originally put together, it was based on that model of cancer classification. But yeah, that's one of the reasons why we like to classify, is because we can then speak in the same language from one practitioner to another. But the classification system that we use for venous disease is something that we refer to as the CEAP classification.
Yeah, CEAP, right?
Yeah, CEAP. Yeah. And there are four different categories within that classification. Most of the time, we utilize the first one, the C part of it, which is referred to as the clinical status of the patient. And that's what we're going to do over the course of this program. And in the next one is we're going to kind of describe each level within the C part of that classification. And there's 6. Starting with number. Actually, the complete classification starts with C0, which means that you have no clinical indication of
which is not me, folks.
Which is not most,
not many of us, I don't think.
Not most of the people that come into the office, but so basically it's C1 through 6, 1 being the least amount and 6 being kind of very end stage. The second part of that is E, which stands for etiology. So, what is the origin of that person's venous disease? And that's basically divided into 3 types of things, either primary, secondary, or congenital. Congenital means that a patient was born with some venous defect that is, causing them, venous problems. And that's not, fortunately, that's not very common. We do see it periodically, but most of the time we're seeing people who have what we call primary venous insufficiency, and that is the inherited type of problem.
I got to tell you that I felt, I don't know if the word is relieved, but I felt educated.
Yeah.
And I think that almost all of us, when you say, well, what's your golf handicap? Well, it's 3, or it's 30. Isn't it somehow important to have a patient realize sort of where they are? And I would imagine that they feel a lot better about getting treatment or options once they know where they are on the pecking order or on the chart of venous disease.
Yeah, I think they do. Number one, I think a lot of people come into, they do. They come into the office not really knowing, what they have and why they have it. But then in addition to that, and hopefully we sort that out for them and, figure out why they're having the problems they're having. But also then we can put them on this, yardstick of symptoms and problems. And I think that gives them a little more comfort to know that, gee, I'm here. I'm not as bad as somebody up here, is C6. These are problems that we have now identified and hopefully can address in a orderly fashion and get their venous status to as good of a point as possible. But yeah, very much so.
Do patients discuss among themselves, because I have in your office, because I think that we have this, I don't want to know if it's a camaraderie but it is relieving to know that you're not the only one.
Oh, yeah.
And I see that when I'm in your office, and I was, as a matter of fact, we get into this a lot later. We talk about this a lot. I think that patients really appreciate that too, because they're in an area where they're sometimes apprehensive. They're the first time, I don't know what's the matter with me. Look at this thing sticking out of my leg. And somebody says, hey, I had that years ago.
Right.
Sure. He's going to fix that for you.
Yeah.
That's the comfort level, isn't it? Knowing where I am.
Yeah, absolutely. And not only there, but, that happens within families and small communities too, because, every day of the week we hear somebody who has come in and they're saying, oh, yeah, I'm the guinea pig. All my family has this, but I'm going to be the first to go through it. And hopefully they go back and give them a good report.
Well, I can tell you one thing, Gag, and this is the absolute truth. I think that when a patient has had some success, that you don't want to just think that it's over. I think that one of the things that I've had to do, and I've learned this with Dr. Juleff in the last over a year that we've been doing this show, and that is being not at ease with what you have, but at least being informed to the point where you can say, okay, doc, I know what you do your part. What's my part? What can I do to either make it stop getting worse or make it even maybe heal itself or fix?
Yeah. Well, I think defining the problem is a huge part of it. Most people come in, they don't know why they're having the swelling or the skin discoloration or the ulcers, that kind of thing. And I would think that that should give them a fair amount of comfort, just, finally figuring out why they have it, and because you can't figure out what to do until you figure out what's going on.
Yeah, and you know what, gang? It goes in overall health. And one of the things that you can do is not only when you find out about this, some of the stuff that we talk about is strictly cosmetic, and that's not what we're doing today necessarily, although certainly at the onset of any venous condition, even if it's spider veins, that doesn't mean you're going to go from a 1 to a 6, but it means that you are somewhere.
Right. Sure. Yeah. So moving on with the classification, so we did C, we did E. So A is anatomic, and that just has to do with the type of vein that is not functioning properly. We've talked about the fact that there's a superficial system, there is a deep system, and that has to do, anatomically in the leg. There's a system that's, closer to the surface than another. And then the perforator vein is the vein that connects the two. It's sort of like an H. And we've talked about that.
It's before. The ladder. I got one in my leg.
The ladder. It's the ladder. So, and then the last is the pathophysiology.
Oh boy, that's the P.
That's the P part of it.
It's the longest one to say too.
Yeah,
pathophysiology.
Right, and that basically what that boils down to is that is the vein problem due to reflux, which means the blood is going in the wrong direction, or is it due to an obstruction?
Okay.
We talk a lot about deep venous thrombosis, blood clots, and blood clots serve as an obstructive type of problem.
I got to ask you this because this came up. A lot of people have reflux in their esophagus. A lot of people, they'll go to bed at night and they'll get this burp.
Right.
Isn't that in some respects what's happening in a vein?
Yeah.
Yeah,
reflux, we use that word in a number of different settings, and basically it just refers to the fact that something's going
in the wrong direction.
Wrong direction. Yeah.
In other words, something that's going into your stomach shouldn't come back to be in your throat.
No.
But you see, the other thing that I do know is that when you say going in the wrong direction, a lot of what you do and what's happened to me as a patient is it's collected at the bottom, in your feet or your legs.
Yeah.
And so obviously it's gone in the right direction, but it what's going to make it turn around?
Yeah.
That's when you need treatment, right?
Right.
Yeah.
Well, and again, it's not that is the wrong direction.
Yeah.
The blood in veins should be going up. Yeah. So. And everything that we do is directed at getting the blood going in the right direction. There's a number of different ways we do that, but
so there you go. So that's the CEAP.
Yeah,
but just to make sure, when you say reflux versus obstruction, reflux, if it's going in the wrong direction,
right,
is it obstruction? It can't because it's blocked even from going in the wrong direction.
Exactly. Yeah. It starts out as obstruction so that the blood can't go in the right direction.
Mm-hmm.
And then at some point, because of that obstruction, then that leads to dilatation of the vein and failure of the valves, et cetera, et cetera. And then eventually it gets to the point where the blood now is not only not going in the right direction, but now going in the wrong direction.
Okay, so I'm pretty well informed. I mean, I've been doing the show. I'm a patient, and I know a lot of people out there listening. There's maybe first timers, or maybe somebody that's a patient or is referring somebody to listen to the show and find out where they are. But what is the advantage of this classification system? I mean, we talked about the cancer part of it, but how is this handy, not just to me, but to you?
Yeah. Like the cancer thing, it's a way to kind of indicate or imply the severity of the problem. So, when we...
is that like the difference between a mild concussion and a full-on concussion?
Yeah. It gives us the ability to, put a number on a patient and then also to, be able to explain that information to the patient so that they kind of know where they are on the continuum of this process that we refer to as venous insufficiency. So it gives us an idea about where they are. Then it also kind of implies how urgently we might want to act on it. If somebody
that's a good one.
If somebody's in the lower classes, 1, 2, 3, it's not quite as urgent as somebody in the upper classes where they really are end stage. They're having severe, not only severe symptoms, but anatomic problems like ulceration, which that's something that we need to address more urgently and take care of the problem quickly.
And there's something else on that, gang, and that is, the reason it's timely is because if you are early stages of venous conditions and you're going to go on a long airplane trip, no big deal. But as you get on that chart, if I'm a 3 or 4, whatever we're going to talk about later on, it may be sometimes when you almost need clearance from your vein specialist to say, I'm planning on going to Europe. What can I do in advance, or can I even go? Will you give me permission?
Well, I think that's a very good point, Mike. People need to know where they are so that they can react to situations that are going to put them at risk.
I tell you what, I know one guy, Grandpa, who is a regular. He's a train wreck. I mean, he's got very bad veins.
Yeah,
and he really, really, really wanted to see his grandson in New Jersey. He lives in Honolulu. And instead, he paid for the kid and the father and the mother to come here.
Yeah.
Because it made sense. He really wanted to see, but his doctor said, traveling that distance right now for you is not a very good idea.
Yeah.
He says, okay, I'll save the money. I'll bring them all over here, and that's what he did.
That was probably a very wise
smart.
decision. Yeah, absolutely. So, and then it also gives us a way to talk about patients. I think you alluded to that before, where, a patient can go from Los Angeles to Honolulu, and we can kind of know immediately where that patient is on this continuum, and be able to kind of jump into the treatment as would be indicated for that particular patient. It's also a way for when we're looking at groups of people from a scientific standpoint. When we're doing studies, scientific studies, to look at, what is the best way to treat this category of patient? Or we have a group of patients that are in this, clinical classification. What can we expect as far as their progression in the future, et cetera? So this SEEP system allows us to be able to classify patients intelligently when we're looking at them from a scientific standpoint. And that's important.
What about this? One of the things that I've learned, gang, we just interject this real quickly because I know we have a lot to cover. A lot of what you do is submission to insurance companies to provide treatment. I would imagine that one of the biggest beneficial things to your profession has been the embracing of the insurance companies to say, okay, this patient is this guy, and this is what we do. This is what we can do to help this guy, and what we can cover. Is that accurate?
Well, not only that is accurate, and not only that, but insurance companies will tell us, okay, you want to treat this patient.
Right.
Well, they have to be a certain, minimal,
stage this or stage that.
Otherwise, it's not going to be covered. So, so it's very, very important with respect to that. The insurance company have started using it.
And by the way, gang, that's one of the reasons why sometimes they will tell you before you do this or before you do that, you have to try this or try that. So they're
right.
I know we won't have time for it, but just keep this in the back of your memory bank. When and if your physician ever tells you, your vein specialist, Vein Clinics of Hawaii, I hope, tells you that you got to wear compression stockings, you got to wear compression stockings.
Yeah.
And that's what I'm doing now. I've completely surrendered to the fact that I'm getting treated, and I'm helping myself.
Right.
Okay.
Right.
So in other words, this is good not just for the patient, but it's certainly good for the doc, and particularly if I'm a doc in New York and your patient from Hawaii visits me, and we can collaborate and get together on really treating that guy right away.
Not only that, but also not only knowing where they are on that timeline, but also then it sort of implies treatment too. What are the specific treatments that we should be indulging in or moving toward with any one particular patient that is a C2, C3, C4, et cetera.
I can imagine when you're talking to docs and other professionals that you're on a very technical level, but you're talking about this chart, but you're talking about the scientific end of it, not the layperson's end of it. So how valuable is that to have you and say another specialist in New Jersey on the same page?
Oh, definitely. There are periodically we have to do that. We have to talk about or talk to a prior physician of a patient, especially in a place like Hawaii, where people have moved to from their places.
Huge numbers of us do that.
So it becomes very, very helpful. So what is this classification? So we're going to talk again primarily about the C classification. That's the clinical part of it. That's the stuff that we can see, we hear the complaints, et cetera, et cetera. These other three parts to the classification are more of the medical side of it. But so the clinical side of it starts out with C1, which is the lowest classification, and basically that just implies that the patient is presenting with spider veins.
These little. Why are they called spider veins? Well, I've had them. and I kept thinking, this looks like a spider's web on my leg.
Yeah.
That's what it kind of was. But also, some of them can just be this little tiny little single string, right?
Oh, yeah.
It doesn't necessarily have to be a big web.
No, they can be, they can be single. They can be in groups. They can, often they sort of fan out. They can be in very typical locations. And I think probably that is as it pertains to underlying venous insufficiency. But we see a lot of people with spider veins kind of on the inside of the thigh and calf. Mm-hmm. There is a particular pattern of spider veins where we see them on the outside of the thigh. Mm-hmm. And invariably those kind of, occur in a fan, type of arrangement and can be pretty extensive. And particularly annoying to those people who have them, and that pattern is based on the the in vitro development of the venous system. Sure. As the blood vessels are developing in the fetus, etc. There's a system of veins that actually are on the outside of the veins that outside of the leg that then become very, very small.
That's pretty amazing, isn't it? Really?
It is, yeah. When you think about it in that
I guess that you better get them veins organized right in the beginning.
Right.
Yeah. Literally.
Happened way back.
Yeah.
So, but spider veins can be either sporadic, and that means that there's no particular reason why this patient has them. They just do. Or they can be genetic. My mother had spider veins and other veins and so consequently I have them. But they are very, very common. Some studies show 80 to 90% of people have some amount of spider veins. Most
of the time, gang, on the program, we talk about the legs. And that's because that's the other end of the heart, and that's where, venous conditions happen. But from what I understand, you can have spider veins or vein issues anywhere. It's just it's way more likely downstairs than upstairs. Yeah. But what about if you see a little veins like somebody's eyes or on their cheeks? Are those spider veins?
Those are we call those spider veins. Yeah. Just a different location. You're right. I mean, spider veins can be anywhere on the body, but I think the thing they can be a little more intense on the legs, and I think that's again just because we walk in an upright position, and most of the vascular pressure is in our legs when we do that, and also especially for women. Their legs are exposed, and it's particularly annoying to, I think, those individuals to have spider veins.
Especially in a place like Hawaii, right? When they're outdoors and playing tennis and go to the beach and all that stuff.
Yeah. But we've treated spider veins, essentially all over the body. Sure. I mean, on the trunk, face, neck, arms, and anywhere. And I think they can arise anywhere. And if it's annoying to the patient, then we try to do something about it.
Here in Hawaii, we have so many different ethnicities and racial groups. And I do know that spider veins they'll get on anybody. Yep. If you see somebody with, really milky white skin, it looks like it's a lot worse than it is.
Oh yeah.
But what about if you are a darker complexion? If you're African American, or if you're Polynesian, do you still get Can you see the spider veins?
Oh yeah. All skin types we see spider veins. Polynesian people in particular have a fair amount of vein disease. I mean, I've learned that just from working in Hawaii now for the last 10 years. But spider veins are very, very common. And yes, darker African American skin definitely they have spider veins.
Okay. By the way, when he says here in Hawaii, I want you to go to veinclinicsofhawaii.com, veinclinicsofhawaii.com, and check it out. And, it started on the Big Island, and unlike most businesses start on Oahu and then spread to the neighbor islands, with Dr. Julep was the opposite. Because you travel and you love the neighbor islands, right?
Oh,
That's when you decided, I'm going to open a practice here.
Sure.
And now, look, you're statewide.
Yeah.
But seriously, I think that this is, I don't want to say it's a relief, but it certainly does make you feel like, okay, you can go now and you can do your own research, and I know a lot of people do, and feel very comfortable with prodding themselves in, you know what, now I think this thing that I have needs to be treated.
Mm-hmm. Yeah, sure.
Okay, so spider veins. Does that mean, if you have spider veins, you're going to have worse other veins?
Sometimes they're connected, sometimes they're not.
Interesting.
One of the questions that we kind of have to address all the time is, all I have are spider veins, and I think they're causing me pain. So the question always is, are spider veins symptomatic or are they not? And, I think theoretically spider veins are not, thought of as causing significant symptoms, especially by insurance companies, because they don't want to pay for what they feel is strictly a cosmetic issue. So as of right now, unfortunately, spider vein treatment is not covered by any of the insurance companies.
And, therefore it's elective. But that's another thing. There's a lot of other things that happen at Vein Clinics of Hawaii, really neat things that are available, other procedures and other treatments. It must be, though, and you certainly become specialized in, there are some people that would probably, even if it's elected, these spider veins, that a lot of work can be done. In other words, you don't have to keep going back every 2 weeks for 2 years to get spider veins treated. No. You can do people in batches, and you can minimize the charging by maximizing the work. Is that?
Yeah, we try to do that.
Do whatever you can.
We try to be sensitive to the fact that spider veins is one of those things that the treatment isn't covered, and so we try to keep it as affordable as possible, and that's what we do. We do that. If somebody comes in for spider vein treatment, we're treating both legs, front and back. That's kind of our routine. We don't do, we'll treat this patch and then come on back a couple of weeks, then we'll treat this patch.
Now, once you're in there, get it done.
That makes more sense.
But there's one more thing, gang. This is very important for you to learn. I think what happens here in these spider veins, the amount of self-esteem and the reason why people elect to do it is it's mostly for personal reasons. A lot of times, you've told me this before, Doc, a lot of times somebody's all concerned about something that most of us can't even identify. I mean, and yet it does make people feel a lot different. I do know that when people come in after treatment, they're virtually, getting up. They're happy. They get real happy about that.
It's amazing. I mean, everybody has their own impression of what is bad and what is worse, and we have plenty of people who come in and think they have just, we hear this all the time. Gee, have you ever seen a case as bad as mine? And often they,
you're nothing. But here's another thing. This is very important. Has also the treatment of spider veins been changed over time? So if somebody said back in the 1950s or 60s, if they'd have had spider vein treatment, it would have been a little bit more painful than it is today and maybe not as effective.
Yeah. Well, and I don't even know what was being done in the 50s and the 60s. I think our treatment of spider veins has evolved over the past 20, 30 years. Originally, way back, the initial medication that we were using is something called hypertonic saline. Mm-hmm. So it was just a saline solution, but it was a very concentrated, form of saline. And basically, what we do is what's called injection sclerotherapy. Mm-hmm. So we inject those spider veins. We use a tiny needle. And a patient comes in, and since we are doing both legs, front and back, they end up getting quite a few little injections, but we want to keep it as comfortable as possible. Hypertonic saline, the response was a little iffier than the medication that we have today.
Oh, okay.
It was a little more painful, too, because hypertonic saline can cause a fair amount of stinging.
Like heat, like stinging or burning. Yeah.
Just with it going in. It has nothing to do with the needle puncture, but just with that substance going into the vein, there can be a fair amount of staining. But we use a couple of different medications. Now, probably the one that I favor is called polydocanol, and it has the best response, I think, in general, and the least amount of downsides to it.
A quick line or two about the needles.
Yeah.
Because some of us, I'm afraid of needles. In the time that you've been a practitioner and a specialist in this, talk about how they've they're way better and way smaller, and I just can't believe it. I've seen them in your office, and they are really tiny.
Yeah,
you know. And a matter of fact, I'm cousin weak eyes. I could not inject somebody because I couldn't see the thing. It's too little.
Yeah. Well, the needle is tiny.
Yeah.
We use a 32 gauge needle, which is about the smallest one that you can get.
And actually, it's not only small, but it's hollow because the stuff's got to get through.
Yeah, sure.
Wow,
it's tiny, and you have to push pretty hard to get the medication to go through that tiny
tiny little hole.
But yeah, so the needle is small, and typically when I'm doing spider vein injections, I'm using some magnification, visually, just to be able to see those veins a little better, because some of them are very, very tiny. So that's what we do. We do injection sclerotherapy. And so one of the questions is always, all I have is spider veins. Should I be evaluated for vein disease otherwise? And that's something that we kind of talk to the patient when they come in. And a patient says, I want to be evaluated for my spider veins. We have them come in and we talk to them because, sometimes it's related to underlying venous insufficiency, meaning that the deeper veins are not working properly.
Yeah.
Sometimes it's not. Sometimes it's just completely sporadic. So we talk to the patient and we ask them all of those questions that we ask. About symptoms and how their legs feel and their family history and et cetera, et cetera. So if they are having symptoms that might be related to venous insufficiency, in general, I recommend that, let's go ahead and do an ultrasound and find out if venous insufficiency is part of this picture.
Okay, now, so as me as a patient, I'm way up this chart. I mean, I'm not end stage, but I'm in pretty good shape. But a lot of times, and I guess it's because some of my venous conditions, I can see them.
Right.
And that's a varicose vein. That's not a spider vein. It's a big old thing.
Yeah.
But aren't there a lot of them that don't get seen, that what you rely on is your own ability to look with the little thing? Hey, by the way, there's this really neat thing Doc has. It's this magnifying thing with a light in it.
Right.
And you put it on the skin, and it shows you what's going on inside. It's incredible.
It's a light, a circular light that we hold against the skin, and what happens is that light is being transmitted in through the skin.
Right.
So we're
like X-ray vision. It's been amazing.
It's called transillumination. So the light is going into the sub-Q. You can really pulls out our ability to be able to see those veins.
But the point I was trying to make is that as a patient that only had spider veins, unless and there's it doesn't mean that you have worse problems, but you need to find out.
Sure.
Sooner or later, you need to say, okay, spider veins are gone. You fix me up. I feel great. But you know what? What if I have something else and don't know about it?
Yeah. Well, and that, again, that all rests on, do they have symptoms? And if they have symptoms, should we treat the venous insufficiency? Yeah, if it's bad enough to get rid of those symptoms. But not only that, but if you have underlying venous insufficiency, then it makes treating the spider veins also more difficult because it's connected. All those veins are all interconnected. And if spider veins are present and the patient also has venous insufficiency, then it can be a cause for spider veins being developed, and then also it makes them harder to treat.
Sure.
The response is not as good, or we have to treat multiple times, et cetera. So those are the reasons why we might recommend that somebody come in and be evaluated. And it's never a bad thing to know what's going on. So, and what are some of the bad things that can happen to spider veins? I mean, most of the time they're just a cosmetic issue, but at other times they can cause problems. And probably one of the main things is bleeding. Sometimes spider veins can become very, very superficial. The skin starts to thin out over the spider vein, and then either they can spontaneously, rupture, the skin can break, or a person will hit again their leg against something, and a fair amount of bleeding can come through a tiny spider vein.
Yeah, aren't there also some people that either from sporting activities or hiking or whatever,
Yep.
if some of those veins are close to the skin because they're right there, you've often said in previous programs that you don't panic because you're not going to bleed out from a spider vein, but you do need to treat it. What do you do if you start bleeding?
The thing that you don't do is run down the street yelling.
Yeah. Everybody, run! No, don't run.
Don't run.
Yeah.
So you elevate the leg.
Yeah.
Hopefully, if you have someone nearby that can help you, that'd be great because if you elevate and then put pressure right over the spot that's bleeding, it will stop.
Yeah.
There's no question about that. It may take a little while, a fair amount of time of compressing it, but then the bleeding will stop, and then you need to be evaluated. Now,
sure.
if you have a lot of bleeding, then it would probably warrant you going to an emergency room or an urgent care center and having them take a look at it, because there are things that you can do immediately to support that area and not let it bleed again. If it wasn't bad, if it stopped, and if you can put a dressing on it, then probably you can wait until you see your doctor in a day or two.
Hearing more and more often, especially on TV late at night, about different kinds of things like blood thinners.
Yeah.
And I do know that we've talked about that before, that there are some people that are taking blood thinners, and if something traumatic happens to a vein or something, that bleeding could be a problem.
Mm-hmm. Yeah, absolutely. Yeah, people on blood thinners, it becomes even more problematic. Yeah. Sure. So then the bleeding, typically we often do see people who come in with not only spider veins, but venous insufficiency. Usually people who bleed from spider veins are those people who have fairly advanced venous insufficiency that goes along with that. And so we have to ultimately take care of their venous insufficiency, and then usually we inject those very superficial veins, thrombose them off, and typically bleeding does not occur.
Any of you that might be out there listening to this, there's a real clear way to find out more by going to veinclinicsofhawaii.com, and it's a great learning experience, and you can see some of these things, and you can say, boy, I thought I was bad. There's some that are bad. Now, those aren't meant to scare you, but they are typically people that are way on this CEAP chart.
Sure.
They're well advanced, and they really need regular and frequent treatment just to make sure that they manage their disease.
Right.
Yeah.
Right.
Okay.
So then you mentioned, just wanted to talk about this for a second. You mentioned spider veins on the face. Do we treat those? Yes, we treat those. They can.
Same way?
We can do injection sclerotherapy for some of the veins, some of the bigger veins on the face, some of the tiny spider veins. Actually, those are treated a little better with a laser procedure.
Oh, okay, that's right. I remember that. Yeah.
So, spider veins in general out there, people are treating spider veins all over with either injection sclerotherapy or with laser treatment. A lot of people are treating spider veins on the legs with laser treatment. If you look at the studies statistically, and you compare big groups of people, etc., the ideal way to treat leg spider veins is with injection sclerotherapy, not laser.
And that's the particular substance that you mentioned earlier. Yeah, that you prefer the medication,
right? Yeah. And so facial, can we inject? Yeah, but for the tiny ones, typically the laser's a little better way to do it.
Boy, that's another thing. We talked about ultrasound. We talk about that a lot. But talk about how that is permeated throughout medicine. I mean, so many new and exciting applications in dentistry and all kinds of things with this laser stuff.
Oh, yeah, absolutely. So what do you do to prevent spider veins from coming back? I think, unfortunately, like a lot of the things we do, we recommend compression, especially for those people who are on their feet all day long. They really need to wear, a good quality medical grade compression stocking, and that will minimize their recurrence of the spider veins.
And in advance, I want to prepare you, because I'm going to make you try these stockings, everybody, every single one of you. Don't look at them as a pair of socks. Yeah. I mean, a lot of people, they balk at the cost of these things, which is really, really minimal when you think of the technology that went into these things. So it's not like when you buy 6 pairs of socks at a big box store for $4. You know? These things, they are medical garments, aren't they?
Right.
Yeah.
Well, they're constructed in a specific way to enhance the function of the veins in our legs, and also they're pretty durable.
Yeah.
And luckily, actually, most of the companies are coming out with a little more stylish kind of appearing stockings.
Yeah, they're in colors. It's great.
You can get dress socks. You can get sport socks. You can get the institutional open toe kind of thing. And
which by the way,
that's
what I do. I got these little open toe deals. Put them on. And they're thin, and then you take another pair of regular stockings that are also thin, and pretty soon you can colorize yourself the way you want it. You don't have to have. Would you like the beige or the beige? Right. Get whatever. So that's good, and get used to that. We're going to talk about that a lot.
So the next C class is C2. Spider veins is C1. C2 is varicose veins. So what does that mean? Does that mean something more than just spider veins? Well, typically, yes. Yep. Because invariably, it's rare to have varicose veins and not to have underlying venous insufficiency. And again, when we say venous insufficiency, we're talking about the veins that are deeper in the leg, not the veins that you can see superficially, but the veins that you can't see. And those are the veins that we need the ultrasound machine to look at. And typically, if somebody has varicose veins, then they have a problem with the function of the deeper veins in the legs, and that's the thing that we have to diagnose and do something about.
Yeah, and by the way, gang, these are not cosmetic, artificial, veins that he's talking about. The spider veins it's an elective deal that you do because you just want to look nicer, but these other ones that get bad, it's not. You don't really have many options. You need treatment.
Yeah. Varicose veins are considered a medical problem by everybody, including insurance companies. Spider veins are not necessarily. So again, like most things in the venous world, there's a strong genetic component. If you have one parent that have varicose veins and vein issues, then you probably have a 50 to 60% chance of having that. If you have two parents, then it's a
done deal.
Yeah,
invariably.
I
got it happen to my family. It's going to happen in yours.
Yeah. So, and why do they occur? Well, they occur because of, again, the deeper veins in the legs are not functioning, and what happens there is that there are one-way valves in those deeper veins, and those one-way valves keep the blood moving in the right direction. When those valves fail, the blood starts to go in the reverse direction, so we have reflux, and that abnormal flow and pressure, as the flow is moving in the wrong direction, it's creating a higher pressure level in the entire venous system, not only the vein that's, abnormally functioning, but that gets transmitted to all of the, connecting veins. And that's why varicose veins happen. Varicose veins happen because they are branches off of the deeper veins in the legs. And as those deeper veins in the legs fail in their function, the pressure goes up, then invariably these superficial veins that were previously normal, varicose veins were previously normal veins, it's just that as the pressure goes up, then they become dilated and, visually unappealing.
Yeah, and I know there's a myriad of things that we can discuss in future programs about the male versus female part of, how many, people get treated and everything else. And I think that maybe in many respects back in the day that it was more thought of as a female disease, and you can explain, why maybe females have more likely a chance of venous conditions because of what their bodies do, right?
Right.
But now, from what I understand, and I see this in your office, there's a lot of men.
Oh yeah.
That and I mean to me, it's almost 50-50 when I'm in your office sometimes. There's a lot of guys getting treated, too.
Yeah, we have a lot of men. Yeah. We have a lot of men coming in. And I keep saying that it's at least 40%. 40% of our patients are male. But it may even be higher. You're absolutely right. I think in the past, probably men were a little more reluctant to come in and be treated because of this idea on everybody's part that it was a woman's sort of problem. But I think as as more and more men are being treated, more and more men are coming in. So it's evening out a little more. But from a theoretic standpoint, women are a little more prone to it because of hormonal changes that happen.
I would imagine, especially during pregnancies and things. Right?
Well, and then also the other thing having to do with women is multiple pregnancies. As you have more pregnancies, the more likely you are going to be to have venous disease. And that's a mechanical problem. That's as the uterus gets larger and larger, it's falling and impinging the flow through those very large pelvic veins, and that can lead to long-term problems.
Yeah, and gang, you go to veinclinicsofhawaii.com and look at some of this stuff and find out how and when you should think about getting treated. A lot of times you're going to be referred to by your family physician or by another practitioner because they can see specific things that say this is something that needs a specialist for. Isn't it sort of interesting the way this is giving people more and more opportunities to even get treatment? Mm-hmm. I mean, there are outside of your clinics. There's places that operate on these a lot. I'm going to guess that the next thing we should talk about in this chart is symptoms and conditions that would make you think, you know what, I don't want to feel like this anymore. I don't want to be tingly, sore, burning, thumping, throbbing, all of these things, and just plain I can't work anymore because my legs hurt.
Yeah, the typical symptoms that we see in people with venous insufficiency are achiness, heaviness, fatigue. I always ask people, do you feel like your legs get tired quicker than they used to? Well, invariably the answer is yes, but often people will say, yeah, well, they do, but, I'm older than I used to be, et cetera. They kind of chalk it up to age, but, there very often is a reason why that's happening, and usually it's venous insufficiency. So those are the three big ones, achiness, heaviness, and fatigue, but people can have swelling. Mm-hmm. People can have muscle cramping. Muscle cramping is a big symptom, especially in the older age groups, because it can be so disrupting to not only daytime activities but also sleeping.
Well, you've talked about restless leg syndrome before. We'll talk about that a little bit, but also and I don't know why this happens because we talked about elevation and we do that again. But there's sometimes when people almost say, you know what, I have to lie down.
Yeah. Absolutely.
That's awful.
Yeah.
Having to stop what you're doing because your legs are sore.
Right. Yeah. In many of our patients, say, gee, my legs get achier and achier as the day goes on, and the swelling, and all I want to do when I get home is put my legs up, and that seems to feel better, and that is completely consistent with venous insufficiency. But restless leg syndrome is another one that theoretically it's about 45% or so of people with restless leg have that because of venous insufficiency. But I got to tell you, in our experience, it just feels like it's much more than that.
And from what I also understand, and I don't know what the medical term is, but I do know a lot of people wake up at night with sore legs or with cramps or all of these things. Yeah. And certainly that it must be a big indicator that you've got a lot going on here.
Right.
Don't just say, well, I got too tired or I was just lying down funny. No, it's something else that's going on.
Yeah. And unfortunately, most people don't. There's not a connection in most people's mind between things like muscle cramping and restless leg with vein disease. It's an easy connection to say, gee, I've got varicose veins. I must have a vein problem. But if all you have is muscle cramping and restless leg syndrome, that's not the first thing you think of. So that's one of the things that we try to educate people about as being symptoms that we really can impact. So if you, getting back to the C2 category of people, if you have varicose veins, should you be seen by a doctor? Should you be evaluated? And, for the most part, the answer to that is yes.
Big fat yes, absolutely.
We do see some people who have, huge varicose veins, and they just, swear that they don't have symptoms. But, after you talk to them a little bit, you get, you hear about the symptoms.
You've often said that this is a disease that comes on very, very slowly. So we're adapting and changing and almost accepting.
Yeah.
But what I really, really am interested in, and this is something that drove me not only to do the show with Dr. Julep, and you, by the way, can go to VeinClinicsHawaii.com and see all about this, is the next big category, which is your C3, which I have, and that's swelling. And
right.
that is, I think, a big sign you have serious issues. You're swelling. You shouldn't be swelling.
Yeah. C3, obviously the next level up. And that is swelling, and is swelling normal? That's the other thing that we sometimes hear. People come in and they say, "Well, yeah, I have a little bit of swelling, but nothing. That's not normal." And I tell them, "No, well, any swelling is not normal, and usually there's going to be a reason for that." So swelling is a little higher level of on the scale of venous insufficiency, and venous insufficiency is one of the prime reasons why you might have swelling. And again, you may not have any other signs superficially on your leg that you might have vein problems. Swelling might be your only symptom, so that always, we talk about who are the people that we should evaluate. Well, swelling always warrants evaluation.
Does swelling mean eventual pain? Because I've noticed that. I mean, if you're really swollen, there's usually a symptom other than swelling. Like tight skin or or sensitive or burning.
Often that is the case. Definitely. Yeah. Some people have completely painless swelling, and sometimes that implies other reasons other than venous insufficiency, because typically venous insufficiency does come along with a little bit of achiness at least. But we see a lot of people also who have very minimal other symptoms, but swelling is the main one. So now, if you have swelling, does that always mean venous insufficiency? Well, not always. Sometimes people have swelling for other reasons. And we've talked about this thing called lymphedema in the past, where the lymphatic flow of fluids is not normal. And that is a very common cause for swelling.
Yeah, I would assume multiplied with both conditions.
Yeah, well, and that's just it. Very, very frequently, people will have both. Venous insufficiency and lymphedema go very much hand in hand. And people with venous insufficiency will often develop lymphedema, in the latter stages of the process of their vein disease. And so often both of them have to be addressed. But are there other reasons? Yeah. Metabolic problems, electrolyte imbalances, other organ systems like cardiac heart problems or kidney problems. They can all kind of lead to swelling. But typically, if people are, seeing their primary care doctor, those potential problems have you often been evaluated already and should be relatively stable.
What's interesting to me, everybody, and I've learned this a lot, and so will you. Go to VeinClinicsOfHawaii.com. VeinClinicsOfHawaii.com. I'm going to make a song about that. VeinClinicsOfHawaii.com. and I think maybe one of the real cool things that I've learned is that I'm much more likely now to recognize a symptom.
Yeah.
Let's say if I have a cut that doesn't, or a little puka that doesn't heal for 3 or 4 days, I think this could be the start of an ulcer.
Right.
Not waiting until you can put your fist in it. And so I think that the wake up call, and that what we hope here is that if you've got one condition, you might have another, and if you've got venous disease, you probably have lymphedema. But isn't it important to have these things on this chart that you're talking about in this class, so that where your treatment is. Don't just go look at something on Google and think you got yourself figured out, because that's probably not true.
Yeah. It never hurts to look.
Yeah.
Absolutely.
Okay, so once again, we're going to come back and do. If you've listened to this program, you got to come back next week, because this is part 1 of 2, and I think that's pretty interesting, because it would almost take months to really learn this stuff. But don't you feel that when people do get educated, that not only are they likely to come in for treatment, but aren't they also likely to be just living a lot better? I mean, isn't there a big reward on what you do, having people happier?
Oh, yeah. And the first step in solving a problem is identifying the problem. And, that's what it's all about. And that's why we do this, so that people will recognize that potentially they have a problem that can be fixed.
See, now you're stuck. You got to come back next week. We're going to do part 2. We hope you've enjoyed what you've listened to, and you'll come back and join us again. In the meantime, please visit either online or in person, one of the doctor's offices, Vein Clinics of Hawaii. That's veinclinicsofhawaii.com. We'll see you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.